at this time, I'd like to open up the questions for the floor. So if you all could fill out your green card and pass it forward. And while we're collecting those, I'd like to kind of follow up Grant's presentation where he took kind of a federal perspective of the CDC crisis, and while we have people really in the heart of things in the states, turn around and ask them, what's happening in your states in the opioid crisis, Curtis and Craig? Would you?
Thank you, Nancy. And really for Arkansas, we've seen a slight decline in the opioid prescription rate over the last year. But unfortunately, our rate is still about twice of what the national average is, so there's considerable amount of work that still needs to be done in that area. But I think the place that we're focused most today and where we think the greatest impact is needed is really around treatment. And specifically, medication-assisted treatment, or MAT, is where we're focusing a lot of our attention, and the need is great in our state. So this is when a physician would prescribe a medication such as Suboxone, which would help the patient or the individual control their cravings and allow them to live a normal life and to work while they're going through therapy. That type of treatment is vastly underrepresented in our state. It requires for physicians to be able to subscribe a drug like Suboxone. They have to have a DEA waiver to be able to do that. And when you look at Arkansas, in a rural state like ours, we have a underrepresented number of physicians who have the DEA waiver, and it's also not geographically distributed in the way that we need for it to be. And so we have a drastic need there, and we're trying to rally the healthcare system and the physician community in such a way that we can improve the rate of individual doctors who have the DEA waiver, especially emergency room doctors, primary care physicians in rural parts of the state, and really embed that in our residency programs as well so that all residents who come out do have that waiver regardless of specialty from day one. And Grant and I were talking a little bit about this prior to the beginning of our event today. And really, that's just to get us to the starting point where we need to be. We recognize that the treatment protocols and the services that are going to be needed built around that is still a considerable amount of work that needs to be done there, but we've got to get to the starting point that we need first, and that's around medication-assisted treatment.
So we're seeing some positive results from our actions over the course of the last several years. We've taken a four-pronged approach. One is to continually adjust our internal policies to help support members that are struggling with addiction. And we're not alone. It goes back to my comment about it takes a village. There are actually 7 Minnesota health plans that are working to reduce chronic opioid use and to share the results. Preliminary statewide data from the Department of Health shows drug overdose deaths and opioid deaths decreased in Minnesota by 17% over the course of the last year, which is a change in trend. Since 2010, opioid-related deaths had doubled. So we've essentially bent the curve. The second is we introduced long-term pain treatment and addiction issues into our HICU, which I had referenced earlier, where we're much more attentive to script trends with personal outreach. The third, as Curtis described, we promoted medication-assisted treatment, mostly in conjunction with providers as well. And we specifically removed prior authorization, which had been a barrier before. And then finally, we work with providers on ways to reduce the overall number of scripts. And at Blue Cross Minnesota, we've seen a 77% reduction in high-risk opioid misuse as defined by CMS over the past 5 years. And as I mentioned, we had started this before this became part of a national conversation, so we've seen some good results.
Thank you very much, and thank you for all these terrific questions. I think because we are here on Capitol Hill, I'll start with a question submitted from Office of Congressman Jeff Merkley's office, and it says, how can we engage as congressional offices? If you could wave a magic wand, what would be the one issue that you would change or like to see change the most? And that's to the panel. How would you like to engage with congressional offices? We're here on Capitol Hill. I feel like I might have set you guys up on that one. I thought, well, what a great question from the audience. Here we are. Go ahead.
I'll start. For me personally, it's around continued vigilance and support. There's so much that needs to occur, especially as the drug epidemic that I'm helping to respond to is changing. We need continued vigilance and support for the prevention activities that CDC is responsible for. So for us, it's making sure that Congress is well aware of how we're using our appropriated dollars, the progress that we're making, and how we're trying to make a difference in the lives of Americans. We take our responsibility, as you would appreciate, very seriously.
I would have two, and I assume that you're asking the question more broadly, how do we advance support for social determinants and health inequities? The two that I would pick is sort of having degrees of freedom for health plans and health systems to do more for their members and patients in the form of supplemental benefits or other things that traditionally we would exclude from the world that we live in. I think having the opportunity, whether it's transportation or food or other strategies, frees up the opportunity for us to address upstream issues. And the second is, I'll be a broken record, I think we need to reward better care, not more care. And I think whatever we can do that really incents the profitability of wellness, not the profitability of sickness, we won't be the only ones getting into the social determinants of health and health inequity business. Everyone will get into the social determinants and health inequity business.
Yeah, and I think, from my standpoint, and hopefully a theme that all of you heard today, is we need more partners. And we see our elected officials being a key part of that. And how can we work together to improve these communities? And I think that's a big part of what we're looking at. When we think about value-based care, and today we think about it more on the basis of how do we incentivize doctors and other providers to provide quality, cost-effective care, when really what we need to be thinking about is how can we take the $30,000 to $40,000 that we spend as a healthcare system on the baby who shows up in the emergency room for failure to thrive, and invest those dollars in such a way that they don't suffer from that condition, that they don't have hunger, they don't suffer from food insecurity, and that's truly a value-based system, and that's what all of us are working toward. But we've got to have allies, we've got to have partners, and that especially includes our elected officials as we're working toward that new and improved system.
Great, thank you. That was terrific answers there. Here's another question from Modern Healthcare that they submitted online. What is the role of social workers in the healthcare systems as we try to address social determinants of health? Will we see increased reimbursement for their services, or what policy changes would help advance use of social workers?
I'll go first. I think that if you look at practices that have very much focused on reinvention, care delivery redesign, you're beginning to see that medical offices aren't just physicians and advanced practitioners. They're pharmacists, they're social workers, they're behavioral health workers. We tend to clinicalize or medicalize everything, including social-related issues, and I think we need to liberalize what teamwork really looks like in care delivery. Some of the more progressive, reinvented primary care models have care advocates or health advocates, not just clinicians. So I think we just have to think differently, and I think reimbursement and employment will change to support a more team-oriented model.
Yeah, I would agree with Craig on that. I think the reimbursement will be addressed as needed, but just as I mentioned during my comments, social workers are critical to our organization. They're embedded in the care management teams. They're doing a outstanding job with advocacy, with navigating the system in ways that are absolutely critical to get people to be able to take care of their own health. But also in the community, social workers are going to be a critical part of things going forward. When you look at the behavioral health needs that we have, the social determinant needs, we see that as being again, use the word partnership, but a critical partner going forward.
And where CDC is investing heavily, you saw one of the new strategies that we're investing in with overdose data action is linkage to care, and obviously social workers and a larger swath of the healthcare infrastructure can serve as a safety net and a bridge to get people into to definitive care and make sure that there's fidelity to care and follow-up throughout. And I think social workers can play a critical role in that.
Great. We are running short of time here. I'm going to ask one more question. We have all of these questions, so I'm going to ask the panelists if you could maybe stay, and for people who really have a burning question to individually come up and ask them. But for the last question, given social determinants of health are closely tied to socioeconomic factors, what should be the role of state Medicaid programs, and I'm thinking of in partnership here, I think, in extending care that addresses social determinants of health? What policy priorities would you recommend for state lawmakers that are reforming their programs? So the question is, how can you partner with Medicaid and pull them into helping combat these downstream problems by investing in social determinants of health?
I mean, I think we're already beginning to see public-private partnerships, and several of our peers in several of our states, and we certainly have the interest in the same in Minnesota, are looking at demonstrations or waivers that allow greater degrees of freedom to include social determinants as part of managed Medicaid models, and even not just managed Medicaid, but recognizing that we can redeploy resources. I think we tend to think of business from a return on investment standpoint, but what if we think of it as return on health? And for our DHS, our argument is every time we spend $1 in a social determinant of health, we are saving the state resources that would otherwise go to treat someone who gets sick. And all we have to do is listen to those examples of the people who are going to emergency rooms because they're hungry. And frankly, we also know that often when people go to an emergency room, they tend to get admitted as well, or a certain percentage of them. What if those dollars were better spent by the state in much more upstream intervention? So I think we're going to see more of these types of partnerships.
Great.
Yeah, I think for me, once the evidence continues to come in about the value of initiatives like the Martinsburg Initiative, is to have dollars available to support implementation of programs like that on a larger scale to break the cycle of addiction, to get very, very upstream. Having visited Martinsburg on a couple of occasions, the power of that initiative is really palpable, and the difference that it's making in those communities, in that community specifically, and the lives of the people that live there is really substantial. So I'd like to get more upstream with big P prevention work.
And from our perspective, and while I don't have any specific policy proposal today, I can tell you that we have had a history of working in partnership with Medicaid and our State Department of Human Services, and it's absolutely critical to have the impact that we need, whether it's on social determinants of health or on value-based reimbursement. When we can partner together and then work with healthcare systems to drive change, it has a much bigger impact. And so we need that type of relationship and that partnership going forward, and we need to have open communication and a way to evaluate and design new programs, and we invite that and think it's absolutely critical.
Great, thank you. And thank you all for joining us today and staying all the way through the bitter end. And I would like to thank Senator Ron Wyden for sponsoring our event today. And I'd also like to let everybody know you can find copies of the speaker's slides and additional resources on NIHCM's website, nichm.org, today, and a recording of the event will be available next week. I'd also like to ask everyone to fill out the blue evaluation cards and leave them on the table. And I would like to conclude with a big thank you to my team, Catherine Santora, Julie Schoeneman, Kirsten Wade over there, Kate Ellis, who Harper back there, say hello, and Carolyn Myers over there, and Caitlin Smith. So I have a great team, and they worked so hard to put this on. So I'd like to include them in our round of applause for our tremendous speakers.